And our insurance company said they wouldn't pay for it and wouldn't cover it. And the hospital, well, I just looked at it and said, well, forget the insurance company, I'll pay for it. I was told I couldn't. And I went through 3 other hospitals and was told I couldn't. And she died.
Oh my
So
goodness.
I sued them for 8 years.
Hello, welcome to the Better Outcomes Show, where we explore the possibilities of a new healthcare. Each episode, we bring you a conversation with leaders across the healthcare industry, exploring topics ranging from new treatment techniques and interventions to novel service delivery methods and business models. And now your host, Rafi Salazar from Rehab U Practice Solutions, a leader in patient engagement and retention strategy. Let's explore the possibilities of a new healthcare.
Well, hello again. Welcome to another episode of the Better Outcomes Show. I'm your host, Rafi Salazar with Rehab U Practice Solutions. And you know what is probably one of the biggest ways or best ways to get negative reviews in your healthcare business? That's surprise bills, or bills that the patient did not otherwise know they were going to have to pay. Whether it's your fault or not, it is always your fault from a customer service standpoint. I've been on both ends of this as a consultant helping organizations kind of with their operations and then owning a clinic myself. And there have been times where we do all the legwork we can, right? Our best due diligence to make sure that we're giving the patient a statement or an estimate of the cost of services that is as accurate as we can make, right? And sometimes, sometimes something changes, right? The availability portal that you used to look at benefits was wrong, or you called the insurance company and then there was some kind of, other factor that the agent or the rep didn't know about, and they gave you one quote and it turned out being something else. Whatever the case may be, the reality is that there are a lot of people who receive bills every single day in this country that are usually a whole lot more than they thought they would be, and in a lot of cases, bills that they were not aware that they were going to owe. So it's one of those things that, like, from a customer service standpoint, I always tell people, you need to do your best as much as possible to make sure that you are staying on top of what you're quoting for your patients. If for no other reason, then you can always show them, like, this is the path we used, this is who we called, this is the reference number, this is what your insurance company told us you were going to pay. Sometimes things change, right? Sometimes coverage changes, sometimes whatever. But you want to do the most you can up front to avoid the customer service headache down the line, because a lot of times if you dig into it, the reason there's a surprise bill or there's the reason something else, the patient owes more than you thought, it's because of some, not carelessness, but you weren't as thorough as you could have been. If you're as thorough as you can be, you can eliminate 98, 99% of those surprise bills. There's always going to be a small percentage that are just totally outside of your control. And you just kind of have to live with those. But what we can do as clinicians is do everything we can up front to make sure the patient is informed before they make a decision. However, I was emailed the other day by the publisher for a book, and I'm going to share the book here. The book's title is called "The Big Lie in My Healthcare Bill: Why I Don't Owe What My Insurance Fails to Pay." And so the guy that wrote this book, he's who I'm speaking with today on the podcast. His name is Frank Lobb, and Frank Lobb is a retired U.S. Navy pilot with a long and distinguished career outside of the Navy. He's done a whole lot of stuff. He was a general manager for DuPont in their process instruments for a while, in their environmental services business. He retired from DuPont, and then he served as a principal consultant for Monsanto, and then the clean air engineering on regulatory law and compliance. So he's got this huge background that's in a lot of ways not related at all to healthcare. But as he shares in the early parts of our discussion, because of a lot of his work and the fact that he was an engineer, when you sign off on things, it's very much like clinicians. You're putting your license on the line every time you sign a document, whether it be a plan or for a certification or something like that. It's your license on the line. So he got very familiar with reading contracts, reading legal documents, and understanding them. That was part of what he was doing, and he explains it in the conversation. And that caused him to dig into insurance agreements, primarily for his insurance company or his insurer, because he shares this story early on about how his wife contracted a disease, insurance denied it, and then the hospital wouldn't let him pay for that out of the procedure out of pocket. And because there's, agreements around, if you're a participating provider, you can't accept other payments. If the insurance company denies service, you can't go charge the patient and all of that kind of stuff. So he talks a little bit about that, and that's kind of the crux of his book, is the agreement that providers have with insurance companies or insurers, and what that means as far as healthcare bills, what true patient responsibility is, and the like. His book is actually broken up into two sections. Section 1 is explaining what you, as maybe an insured, is actually owed by your health insurance company. And then Section 2 gives you what he calls the means of stopping these outrageous medical bills. So anyways, it was an interesting discussion, primarily because I think a lot of times when I have discussions with people about insurance and payment and what's going on, it is somebody else that's versed in healthcare, that comes from a healthcare background, or maybe even a legal background. They're an attorney or something like that, and they're looking at contract law. This is a conversation with somebody who very much is an advocate for healthcare transparency and financial transparency, that doesn't come from a healthcare background. So he does approach this problem, if you would, from a different angle. He's not playing the healthcare quote unquote game, because he's an engineer by trade, which means he's thinking about things a little analytically. He's used to looking at contracts and stuff. So we'll break down a little bit more after the discussion, but at least go into the interview kind of understanding, like, this is a guy who came up against medical bills and was trying to figure out a solution, and kind of dug into the issue as he sees it. And he presents a solution, which we'll just discuss in a little bit, but I don't want to talk about it anymore. So without any further ado, here's Frank Lobb talking about medical billing practice inconsistencies, or why you might not owe what your insurance fails to pay on for your healthcare service. Well, hey, Frank, welcome to the show. How are you?
I'm fine. A little snow outside, but other than that, I'm inside, so we're fine.
Great. I'm excited about diving into the world of surprise medical bills and kind of navigating those super, super complicated waters. But before we get into that, why don't you tell us a little bit about yourself, your background, and then what led you to what you're doing now with the book and all that?
We're going to have some fun with this, because I've lived a lot of lives.
Yeah.
I'm a retired Navy pilot, flew 20 years. But then I was a general manager in the DuPont organization. I was knee deep in the middle of the negotiations and the structure of the Clean Air Act.
Okay.
I was a consultant across the country on what constitutes compliance with state permits and regulars and contracts and so forth. And I'm sitting in our family business, which is a hardware supply business. So yeah, I'm an old guy, but I'm still kicking. And we also, by the way, run a farm.
Oh, okay.
Nice farm where we live, and so I've done a lot. But the reason I'm into this is, excuse me. A number of years ago, I was married. My wife had a problem. She was in the hospital, almost died. Doctor pulled her back. They needed additional care. Doctor begged for it, and our insurance company said they wouldn't pay for it and wouldn't cover it. And the hospital, well, I just looked at it and said, well, forget the insurance company, I'll pay for it. I was told I couldn't. And I went through 3 other hospitals and was told I couldn't. And she died.
Oh my goodness.
So I sued them for 8 years. Okay, by the way, I am remarried, I got a good family, and life's good. But that lesson never left me, because it is just so wrong. And because I had the experience of being in court, negotiating the Clean Air Act and a whole bunch of other stuff, I felt I was competent enough to go in and look at how in the devil an insurance company could block me from personally paying for my wife's health care. And it took 3 years to get access to the contracts. Well, what's unique again about me is I spend a fair amount of time reading contracts and writing them. So I knew what I was reading. And what the public thinks health insurance is, and what those contracts say it is are entirely different. And I would argue that as we go forward with the, well, how do I want to say, the streamlining, the more efficient healthcare system, and backing the doctors out and so forth, that the structure they have for health insurance is indefensible and it's going to cause major problems. The book I've written, The Big Lie in My Healthcare Bill, is because the structure of those contracts is all around having people think they have insurance. Okay? Because as long as you think you have insurance, you think you own it, you think they're going to pay for it, and so forth. If you back it out and look at it as simply a plan that you do not own, the doctor isn't yours, so forth, there's a problem. Because what, more than 50% of family bankruptcies now are a healthcare bill?
Yeah.
This Consumer Financial Protection Bureau and a number of others have come out and called the bills ripe with error, more than 80% in error. The industry has a problem. And what I'm going to argue is that they're too far out over their skis. And my book exposes it. Now, my book may fall flat on its face, but somebody is going to expose it because it is too simple. If you read just the AMA's own words to their doctors, their membership, what they say is insurance will generally pay.
Yeah.
If it does not pay, then you have to absorb the cost. Well, where do they tell the public that? Who's going to tell the public they don't owe their healthcare bill?
Yeah. Yeah. So I guess then the first leadoff question to that would be like, okay, what are people actually buying when they buy a health insurance plan? You know, Blue Cross Blue Shield, maybe it's through their employer. They're like, okay, I need to get healthcare for my family or whatever. They sign up for this plan. What are they actually signing up for then?
They never sign up.
Okay.
You got to separate something. A piece of paper may float through the past
The HR department.
You want it to sign up to join. But if I join the YMCA, I sign a piece of paper somewhere. But it's not a contract. Okay? There's no contract here. Insurance requires a contract. So the majority of people in the United States simply are a member of a plan, like they would be a member of the YMCA. The plan is owned by the employer.
Yeah.
For those who are not employed and get their insurance directly, then they pay an insurance company by the month to be part of the insurer's plan. So the plan is almost always owned by the employer. Those that have to buy it on the exchange, it's owned by the insurance company. But the key piece here is you have no ownership rights. So if you think you have right to coverage and payments and those things, no, not in law. You have no ownership whatsoever.
So at that point, I guess you're talking about, if your insurance company or the plan of which you're a member decides you're not going to get coverage for XYZ procedure, you really have no legal recourse because it's all up to the determination of the payer, in this case, whatever ABC insurance company will call them. What they decide is, worth them paying for or not, right?
35 years ago, the Supreme Court unanimously ruled that insurance companies have the right to ration healthcare. And it really says to induce the rationing of healthcare. And what they said was the insurance companies have a right to determine coverage.
Yeah.
And limit it. So when you try to sue for lack of coverage, you have no standing is the right word in law. I was in the court for 8 years. Now, they didn't want to let me know I had no standing, but they could have thrown me out of court the first day I filed charges because I filed for breach of contract. And there is no contract, okay? And I have no ownership. But they covet that position because it's what we think we are owed, And then we roll over, and when the bill comes in, we think we owe whatever hasn't been paid,
Yeah.
leaving a big hole in the middle.
Yeah. So I guess then, what, like being a provider myself and signing some of these contracts and kind of being in the room when some of these contracts are being signed by provider organizations, when they get in network with, XYZ insurance company, like there is a clause in those contracts that the provider agrees to. If Rafi comes into the clinic and ABC insurance company deems it not medically necessary and they deny it, the hospital shall not bill, I think is the words, or shall not pass on the cost to the beneficiary. So is it something in the in-network, out-of-network status that's causing some of those bills, or kind of how do these bills kind of pop up if the insurance company has a contract with a provider that says, hey, don't bill Rafi if we deny this care?
Well, let's break things in half, or at least
Sure.
Most insurance is in network. Most billing. I think it's less than 10% of all the healthcare bills are out of network. If you're out of network, it's buyer beware, like it is in any other market. And the government messes around with it a bit. But if you get your healthcare out of network, you're on your own.
Yeah.
You have no rights, really. There aren't any contracts. And whatever you're billed.
Yeah.
Case closed.
And I think in 2022, they came out with the No Surprises Act, right? That said that out-of-network providers needed to give patients a good faith estimate. And then if it's, if their bill was more than, I think, $400 is the threshold, then that estimate, then the patient can go and dispute the charge, right? So there's a little bit there for out-of-network folks.
There are bits and pieces, but I'd hate to have to argue that case in front of a judge.
Yeah.
I'd much rather be on the other side. The reason is, how do you know what the cost is going in? In other words, I plan an operation and I say it's $1,000. And then I go, oh my goodness, look what I've gotten myself into. We have to do other things.
Yeah.
Okay. And so when it's going to be an argument between the technical folks as to what was necessary, with you caught in the middle for the cost. Yes, there's some protection, but I wouldn't want to bet the farm on it. Okay. You need to be in network. And that's what we ought to talk about today, because that's the big problem. I was in a presentation on Medicare Advantage, and we think that's Medicare, and they tell you it is. It is not.
I was about to say, anybody in healthcare can tell you it's not, right?
Right? It's the same insurance you get from your employer, or you buy over the exchange. They're under the same contract. Nobody wants you to think that. But let me explain I had a presentation. I sat there for about 45 minutes and I listened, and I finally said, oh, I got a problem. You keep downplaying Medicare and you call this Medicare Advantage plan of yours Medicare. It's not. It's private insurance that the government buys. The second thing, you keep talking about benefits. Under Medicare, my benefits are in law. I'm guaranteed them. Under Medicare Advantage, I'm not guaranteed anything. Matter of fact, you have the right to refuse coverage to zero. And he blew my mind. He said, well, you're right, but we have other advantages. And a woman sitting next to me elbowed me in the ribs and said, I thought we got insurance to protect ourselves. The other benefits. But what we've done is we've gotten people to believe that they're buying insurance. And when something really goes wrong and you get stuck, 3 days in a hospital is $30,000, $40,000.
Yeah.
And the average person can't afford a $400 surprise bill. People get hurt badly. And when they get hurt that badly, people get angry. And there's the shooting up in New York, I would argue, is built on rage. Those people are angry. Now, I'm not saying they're justified, but you can find if 50% of the families in the country or family bankruptcies are for a healthcare bill, there have to be a lot of very disillusioned, unhappy people who thought they were in good shape.
Yeah. So, and it totally makes sense on that level. So speaking of in-network providers, I guess let's start at the beginning, like what are you actually owed? Let's say you're a member of ABC Insurance Plan or whatever. What are you actually owed from them in that agreement? Because it's not a contract. You're not signing a legal contract. The plan is owned by your employer or XYZ, whatever. What are you owed as being a member of that plan?
You really bring something up that's very significant. I'm an engineer by training, okay, and degree. I worked for DuPont for a period of time, and I signed a lot of drawings and contracts. I did not sign as DuPont. I signed as Frank Lobb because I'm an engineer. My license is Frank Lobb.
Yeah.
Okay. What I'd say to you and your membership, or your listeners, there's a problem developing. I've been asked to talk about AI at times. And when I've talked about it, I've said, hey, we're off base here. I'm more than willing to understand and agree that the technology is going to be here and it's going to be used. That's just advancement. But how do you handle the responsibility, the liability side? In other words, if I'm a doctor and AI figures out what the necessary healthcare or the procedure is, and they want me to sign for it, and I don't even understand how AI got there, doesn't that leave a big hole?
Yeah.
So unless we're going to change the system, which I find hard to believe because it's the same for an attorney, engineer, a number of professions, somebody has to put their name on the line as certifying that this is the correct procedure. And eventually somebody's going to cut off the wrong leg, and you can't point at the computer. You're going to point at the guy with his name on it. And what I'm going to argue here is that it's just not the technology side, it's the billing side. Government wants to say, well, we'll figure it all out, we'll explain it, and put some safeguards and guardrails. 77,000 billing codes. How in the heck?
Growing every year, right?
Could anybody understand it? And I could run anybody in circles. I know enough of it. Like, okay, we're going to have a co-insurance or a copay. But if I can't bill, how can I have a copay? How can I have co-insurance? It makes no mathematical sense. And what I'm going to argue for your listeners, we are getting in the position where the insurance companies have built a kludge. They've built a trap. It's held together for all these years, but as we become more and more exposed, the system is going to be exposed. And then you, as an individual, as a doctor or a hospital administrator, are going to have to be willing to stand up and defend this thing. And I'll give you one more example. I had a small operation, and I wound up in the the operating room, and they literally came in with a credit card machine while I'm laying there ready for the operation, and they wanted $3,000. Well, I needed it, so I gave them the card for $3,000, and I got it, and I came out of there, and I immediately called my card company and told them to cancel it, and then I filed a complaint on fraud because they had no right to bill me. That's what the law says. Okay, the $3,000 came back immediately. The surgery unit for a major hospital didn't even try to defend the bill. They just gave me the $3,000. They sent me two letters inviting me to come back for a follow-up, and then they sent me a birthday card. But they did not one time try to defend their right to bill me. That tells you a lot, because this is coming out of a major billing office, and these people know exactly what they're doing. They just thought I was dumb enough to accept the $3,000 bill and walk away. And the point I would like to leave with your listeners, you can't defend the bill. If somebody raises their hand and says, show me the numbers and show me the terms in your contract that let you bill me, how do you do that? And
yeah.
let me add one other thing. Any contract you find has a come on, my mind, I'm getting old. Uh, it's a review process that allows them up 30 days, 60, 90 days to go back and look at whether it was appropriate to cover something. And if you look at the language of those, in all cases, it says very clearly that they have the right to claw the money back. So you're the doctor, you've already been paid, you're the hospital, you've been paid. The insurance company 30 days later decides, that was a mistake. It's going to hurt our bottom line. It's going to hurt our profits. We want the 10,000 back. You, as the hospital or doctor, you have to return the 10,000. If you don't, they have the right to claw it back from future payments. And you cannot bill the patient.
Yeah.
So if anything is going to tell you that you have no right to bill and it's indefensible, that clause never brought up, but it's there in spades. And if you go through these contracts, the inability to bill isn't in there once. It's in there like 4 to 5, 6 times.
Yeah. Well, and how much, let's say you go in, this is for in-network primarily is what we're talking about. Like if you're, if the provider accepts ABC insurance, you're a member of ABC insurance, there's a provider payer agreement, and then ABC insurance says, no, they claw the money back from the provider. The provider can't go back and bill you for this service, right? Why are these bills coming out then? Is it just like bureaucracy, these hospital, whatever, some bean counters in there said, oh, this money got clawed back, we just revert it to the patient, we turn it to patient responsibilities, and the bill automatically goes out? Like, is that just the function of the system being so big and complex that no one's really taking the time to tease that out, and it's just easier to send the bill out? Or what's actually happening there if providers know they can't bill?
Well, if you look at this, for years, you go into a doctor's or particularly a hospital, and they give you a little piece of paper where I sign and I agree to pay whatever my insurer doesn't pay.
Yeah.
And it doesn't say my plan, it says my insurer or my insurance, right? So I sign that. Now, people think that piece of paper means something, and they will tell you it does. It does not. You can't sell a car twice. They have earlier in their provider agreement signed away the right to bill. So it means nothing, but you and doctors and the hospitals have been led to believe you could put that little piece of paper in front of somebody and then transfer the responsibility. So whatever you don't get paid, you can pass on. And the customer doesn't understand the difference. The game is changing because of the government action, the Consumer Financial Protection Bureau, and so forth. People become a lot more sensitive to it. And when challenged, I'm seeing billing offices and doctors' offices, hospitals, acknowledging they can't bill you. Now, 3-4 years ago, that was not true.
Yeah.
They would argue they had the right to bill. And what I'd say to your audience is, well, let me come at it another way. I've had a long career in managing and problem solving. And the way I have always approached it, I want to go to 30,000 feet, look at the big picture, and see where it's going, and then get to where it's going, okay? I don't want to get down in the grass and fight about today. I want to realize where it's going to be in 5 years and be the first one there with the mostest, okay, with the solution. If you look at where healthcare is going, we're going to get more and more efficient, which means the doctor is going to have less and less time for the patient. They're talking about 3,000 patients. How do you treat 3,000 patients? My own doctor lost a patient that he didn't lose him, the system lost him. Guy died. And my doctor asked me what he died from. Think about that. He's asking me what the doctor said.
Yeah.
Said the hospital did not take time to look at it. Terminology for the hospital, they treated him and streeted him. Okay, that's hospital emergency room terminology. They took him in, did no more than they absolutely had to, threw him out, and he had to be rushed back to a hospital He went to a different hospital because he had to be airlifted, and he died. And my doctor sat there literally with his hands in his head, his head in his hands, and he said, "Frank, I'm old enough to remember when I could take care of my patients, but they won't let me anymore." And he works for a very large,
large corporate
organization. Now, I'm not bad mouthing the healthcare industry. We've got great technology. There's still a lot of great people and so forth. But when you build a system that just can't go forward without really damaging people, and people are beginning to wake up to it, I would rather understand what it is and how it works in truth and be prepared to deal with it. And I'll say one thing specifically I think would help your listeners. The key piece in all of this is responsibility. I have a dentist. It's a little different. Dentistry is not medical treatment, and healthcare is different, or the insurance is different, and so forth. But I've helped him in one area. He gets a lot of pushback on denials. The denial this, denial that, and various coverage. So I said, hey, look, this is easy. Make him go on the record against your dentist determination. In other words, he's a licensed dentist, and if he says this is necessary care, make them say it's not. And that's in spades in health and on the medical side. What they want you to do is believe that their doctor has the same right to determine medically necessary care as you do. Oh, no, they don't. But as long as you don't call them on it, it turns into a discussion between the insurance company doctor who sits in Chicago and the patients in New York.
Yeah.
And the doctor in Chicago won't even look at the record, because the minute he touches the patient, he picks up the responsibility, the liability. And it's a huge hole in their boat.
Yeah, you're talking about things like utilization review and prior authorization and all that, where you got peer-to-peer reviews going on.
You're rolling two things together there. But yes, but the point is it all rolls around the contract says that you have to provide medically necessary care at all times.
Yeah.
And they want you to believe that their doctor sitting on the other side of the country has the same standing as the doctor at your bedside to determine what the care you need is. Am I making sense?
Yeah, no, it makes sense. I just think, like, playing devil's advocate, like, I would think the insurance company would say that there's moral hazard there if there's not a checks and balances, right? Like, if in-network providers are left to bill, say whatever, this procedure is medically necessary, and then that procedure is medically necessary, the outcome or the spend or the outlay for healthcare expenses would quickly outpace what they're able to bring in premiums. So in their minds, they're probably thinking that, okay, if we have another licensed clinician that can look at a chart or can look at a situation and say, yes, this is medically necessary or not medically necessary, then it saves those situations where an insurance company might pay for something that in fact wasn't medically necessary, and that lowers the cost for everybody, right?
Exactly. But there's a different way of handling it than they're handling it today. If I were a doctor and I had somebody and I felt there was some necessary health care I had to deliver, and the insurance company refused to provide coverage, I'd get on the phone and say, look, this is simple. You're going to share the liability here, and we're going to do this technically, or I'm just going to simply say this is medically necessary and force you to make that decision. Because what they really want you to do is talk only about coverage and allow you as the doctor to hold the liability side.
Yeah.
Making sense?
Yeah. So the payer is trying to
have the right to deny coverage.
Yeah.
What does that have to do with my obligation for medical necessity? It's apples and oranges. Take a person where, if you want to get in a fight, take the other side to where they cannot go. And so rather than argue coverage, let's talk about medical necessity.
Yeah.
And make them weigh in. I'm going to go back to engineering. It's done all the time. If we build a bridge, engineers don't always agree as to what the best building, but we get in a room and talk about the engineering. And then we come up with a consensus and we sign off on it. What health insurance wants to do is have this guy off in a closet in New York, never even looking at the medical record and making a critical decision as to what you can give the patient in the way of care. Right? If I would advise, if I were a doctor, what I would do is make them take the position of it's medically necessary care. Don't put the burden on me. I don't want it. I'll share it, but I'm not going to take it individually.
Yeah.
And
what you're saying is those in-network plans that or those payer agreements state that the payer, the insurance company, is going to pay for all medically necessary treatment that's covered, right?
Yeah.
Okay. So you're talking the discussion really needs to stop being about who has the right to refuse coverage and really needs to be about what is medically necessary and who's where the burden of proof rests. Does it rest on the doctor in the room with the patient, or does it rest on a third-party reviewer or a utilization management company or something like that?
You're taking the other side where they don't want to go. They want to deny coverage freely, and you responsible for the medical decision. That's not fair. And it just everybody's eyes glaze over. And I would say that's the paperwork and the phone calls and the arguing back and forth with there was a report where I think it was Amana. They had a former medical doctor who was high up in the Amana. I think he was the director for Humana. Anyway, he testified he never looked at a medical record. And people were shocked. And I kind of just laughed because why would he? If he looks at the record, he takes on liability for the decision. If he doesn't, he can just sit off on the side and say, well, in most cases, this isn't required. It's his view, but there's nothing legal hanging on it. There's no legal liability. And the poor doctor on the phone, he's got to make the decision in terms of the patient's health and life.
Yeah.
Put them both on the same page.
And that what you're saying now is that's currently not happening. So if ABC insurance company's utilization review firm or peer review firm is calling, this clinic about whatever procedure they're denying, you're saying they haven't looked at the patient's chart or their record, they haven't gotten too involved, and that's what's keeping them in a legal position where they don't bear any burden or legal liability for the denial of care?
Absolutely. Look, I'm an old guy, and I've done a lot of. I'm 87. Anyway, I've consulted across the country, and I've done contracts and so forth internationally. I very seldom find anybody who can read a contract and understand it. I never read one once. I want to read it 3, 4, 5 times because there are things in there that you just don't pick up the first time through. Doctors don't have time to read these things.
Yeah.
They don't understand them, and they're just being dragged along.
Well, and honestly, it's probably like their practice management firm or company is signing these agreements for them. They're not even looking at the agreements half the time, I'm sure.
I'm going to try to sell my book a little bit. It's not meant to sell books. I don't care with any of the money involved. I'm comfortable. I don't need this thing. But it helps you understand how the system's been put together. And what I found for myself and my wife and my family is when I walk into a hospital or wherever, they treat me differently because I understand how the system works. And I can talk to them as an equal. Does that make sense?
Yeah.
I think what the doctors, the hospitals, and the rest need to be able to do is talk to the insurance industry as equals, which means you need to understand not what the insurance company tells you is in the contract, but what's actually there. There's a contract in the back of the book.
Yeah.
Simplified, but representing of what all these contracts are, and they're all the same. They change a little bit in
And
the wording,
boilerplates or whatever.
but structurally they're the same. And let's say this, it's impossible to have different ones for different plans. In my area, you have Independence Blue Cross. Well, they're married with every other Blue Cross organization in the country. Independence Blue Cross has probably at least 3 different corporate shells giving plans, Keystone being one. And all of these different organizations have multiple plans.
Yeah.
How many contracts would you have to write if every plan had a contract?
Oh yeah, hundreds or thousands.
It's impossible.
Yeah.
Okay? And each one has to be state approved. It can't happen. So it doesn't. You have one contract that applies to all of it.
Yeah, which is why providers, when they sign an agreement with, Blue Cross Illinois or something like that, and that's for all the plans in Blue
Because
Cross
they're all
Illinois.
married.
Yeah.
Yeah, they're identical. And it's going to be the same Humana, whatever. You pick it.
Yeah.
So they can't change. So when you have a plan that says, well, we gave you 80% last year, we're only going to give you 70% this year, that's not a change in the plan or contract. That's just, since the insurance company has the right to deny coverage whenever they want, they've just arbitrarily decided that they're only going to pay you 70% this year. But if I went into a discussion with them, I'd sure want to talk about the general contract.
Yeah.
Not the plan. I couldn't care less about the plan. I care about the contract. And it's someplace that the insurance industry really doesn't want to go. They don't want people talking about that single contract out there, because if you get into the terms and conditions, it's dramatically different from what they're selling on TV.
Yeah. Well, I think you bring up a good point. We talk about a lot on this show about a lot of the challenge in healthcare is the disparity of knowledge and understanding about what's actually going on. But we really have always talked about it from the patient side, right? Like, patients don't really understand what their insurance plan is going to cover or not going to cover, and that in and of itself changes the buying decision on their side of things, right? Like, they're unable to make an informed decision because they lack sufficient knowledge. But you just brought it up on the provider side too, that a lot of times providers themselves are in a situation where they're left making, decisions about potentially providing some care that they would think is medically necessary, and not really knowing, what the person that they're or the entity that they're contracted with to pay for it, whether or not that's going to be approved or not approved, and what the recourse is, and all of that. So,
I used to do a lot of contract negotiations and particularly compliance issues with states across the country on big emission sources, big plants, and so forth. And you get to a position where you cannot really get them to agree as to what is necessary for compliance and so forth. Not a lot different than what we have here. What is medically necessary? And I used to do this routinely. I'd send a letter to a regulator where there was a gray area and there was some argument and they wouldn't go along. So I'd take whatever I felt was the responsible position and I'd say, this is my position. And unless I hear otherwise from you in writing, I will assume it's correct and go forward. Now, you can do that a number of ways, but you really put them in a bind because they can't afford just to remain silent. And unless they're going to take responsibility, they can't answer it. So they don't. And you can move forward. So where you have a problem, and I don't have this in the book, but you can share this with the audience. If I had a patient that I needed something done, I'd just scratch out a little piece of paper and this is what I believe needs to be done. And unless I hear otherwise specifically in medical terms, I'm going to go forward, assuming they have coverage. I can't imagine an insurance company wanting to go into court on that.
Yeah.
They'd lose. One of the things about, if you go back to my situation, was I said, I wanted to pay for my wife's care. Why do you think they said no?
Why the provider said no?
Yeah, the contract says no, but why do you think they refused?
Well, because there's probably I know in a lot of provider agreements it says you can't
You
you
can't
can't
bill.
accept payment from the patient for things that are covered by the
Yeah, but
plan.
if they had just done it, my guess is everybody would have kept their. They'd have found some way around it. But the problem is exactly what was on my mind. I said, I'll pay for it, knowing that after everything was done and my wife was cared for, I could take that into a court and win it. So if I had a $10,000 bill and was guaranteed necessary health care, and I had a doctor saying this was necessary health care, because you can't get any care unless it is medically necessary, right?
Yeah.
What do you think a court's going to do when I say, my doctor says it's necessary, my insurance is simply refusing to provide the coverage they promised me? You'd lose, but you'd lose big time. So they bury it. They do not want to go to court, which means they're not going to let me pay. They're not going to let me get the care. And if I don't get the care, there's no way I can sue based on the cost.
Yeah.
And and the coverage end, they're fine because they have a right under Supreme Court ruling. They keep themselves clear. And so they won't even let me pay. But somewhere along the line, this thing is going to break because you're familiar with the contracts. You can't defend the terms there. And yet the insurance industry is out saying, something dramatically different.
Yeah. So I guess we've got a few minutes here. So as far as like going forward, and we are in a time, I think this is early 2025 when we're recording this, but there's obviously been a whole lot more discussion in the public discourse around health insurance and coverage and what is healthcare and not healthcare. Like going forward, how do you have any suggestions or thoughts about like how do we make this muddled mess more clear and then make it more transparent so that we don't get in a situation where people are being denied coverage for things that should be covered, or people go into something thinking they have coverage, or that it's going to not be denied and it is denied? Like how do we kind of clarify what's going on from maybe even from a public policy standpoint?
I think the doctors have to be a lot more knowledgeable about how the system actually works so that they're not signing as responsible parties for things they're not a part of and don't agree with. And we're getting to a point where if they don't do it, the system's going to get really worse because we're going to lose 20% of our doctors, and they're going to try to have nurses and whoever assign necessary care, but the doctor's going to have to sign for it, and the AI is going to do it, but the liability stays with the doctor.
Yeah.
And that doesn't work. And at the same time, you have costs going through the roof. And what we talk about is greater efficiency. The math for greater efficiency is that I have to deliver less faster than the cost of healthcare is going up.
Yeah.
Right? That's impossible because what we're talking about is efficiency is going to give us greater access for more affordable access. That's mathematically impossible. And so with 20% of the doctors forecast to leave and the medical costs going through the roof, and at the same time, the ability of the average American to pay for this stuff is going down, there's a crash point. So I just am a firm believer that you make out best in a situation if you understand the rules of the game. And where most doctors are today, they don't have a clue what's in my book. It's not insurance. It's not your plan. It's not the doctor, because the doctor's under contract to somebody else. Most of the doctors now work for a large hospital.
Yeah.
Okay. So, but on the other hand, that doctor still works for me. He may get paid by, in my area, it's Penn Medicine, but his license is individual. There is no Penn Medicine license. Okay. So that's critical. And the doctors are being pushed more and more to a position that's not defensible. They don't have enough time to truly treat the patient. Am I making sense?
Yeah, and that opens them up for personal liability on their medical license, is what you're saying.
If this was a bridge, you gave me 10 minutes, say 15 minutes to look at the drawings for a new bridge and put my name on it, I'd tell you you're out of mind and walk out of the room.
Yeah.
Because my name on that document carries liability. And the doctor is still the key point of liability, wherever he puts his name. And its system right now is set to just hang the doctor out to dry.
Yeah. Yeah. That's a point I don't think anybody's brought up on the show before. So
we just look at the trends. The doctor is in a lose-lose position. And when you're in that position, it's best to fully understand the rules of the game and then take the other side where they can't afford to go. And where they cannot afford to go is who is literally responsible for the medically necessary decision. They don't want to touch that. They want to talk about it as coverage.
Yeah. Cool deal. Well, Frank, thanks so much for being on the show. Where can people find out about the book, connect with you if they want to learn more about the book, The Big Lie in My Healthcare Bill? Where can they go do all that?
It's on Amazon and Barnes and Noble.
Okay.
But the easiest way to get it is go on the internet and look up killabill.com.
Okay.
K-I-L-L, capital A, B-I-L-L.com. It'll carry a lot of information, and it leads you right to the book. The QR code will take you right there. Again, please, whoever hears me, I am not selling books, but you're not going to find anybody with the information I have in this book. It's not out there. And the people who claim that, let me say one other quick thing. The people who write books, and I've read a ton of them, come at this thing totally backwards. They think that the healthcare system is in business to treat patients, and it was at one time. Today's healthcare system is in business to make money. Now, there's nothing really wrong with that because that's what every business is out for, right?
Yeah.
Except healthcare is the only business where it is a monopolistic business, regional monopolies, in a totally inelastic market. And if you said that in an economics class, they'd tell you you're out of your mind. You cannot turn a monopoly loose in an inelastic market and tell me you're going to reduce costs and make things more affordable. It's impossible.
Yeah.
Am I making sense?
No, you are.
Tells you flat out. There is no response to price. And this isn't my determination. This is the determination of economists across the country. It's an inelastic market. It's probably the only one in the country. Because when you need it, you need it. You know, you're not going to shop hospitals when you've got a heart attack.
Yeah, exactly. Yeah. Well,
anyway,
you bring up a point.
This, and I don't mean to drag you out. So.
Yeah. No, it's great. What you just said kind of reminded me. I don't know if you've read. I'm looking for it on the shelf. It's called Enough, the book by Jack Bogle. So he founded the Vanguard Group, but he talked a little bit about healthcare in the book, and he said something along the lines of like healthcare is at a position now where the needs and the benefit of the patient are subverted by the incentives of the market, right? And that's kind of where we find ourselves today in healthcare, where a lot of decisions are being made not based off what's medically necessary or even in the patient's best interest, but on the benefits of commerce, right? So, awesome. Cool deal. Well, and that's not awesome, but you know, if people become aware of it, then we can maybe make some change. So, Frank, thanks so much. We'll link to the book and all that in the show notes, and have a good one, sir.
Yeah, if you have any other questions or anything, just get back to me, and I'll be more than happy to try to answer them. Okay.
Awesome.
I really enjoyed it. It's been awesome, as you said. Okay.
All right.
Thank
Bye.
you, sir. You have a great day.
Well, I hope you enjoyed that conversation with Frank, talking about surprise medical bills and really what's going on as far as what you owe, what the agreement is between the insurance provider and yourself as a member and that healthcare provider, and the dichotomy, the entire mess of an ecosystem. What I always tell people, I was actually just lecturing about this the other day with to a group of graduate students up at the university here, and I was talking about medical billing and providing estimates to patients, and really the way I tackled it, or the way I always address this, whether it be in the practice that I run and operate or when I'm talking with other organizations, is that healthcare is probably the only area of the economic realm, because there is a financial transaction taking place, where the recipient, the end recipient or beneficiary of the service that is being purchased, has very little, if any, true understanding of the way the finances work out, right? Many people understand, oh, I think I have a copay here. I think I have an insurance, a co-insurance here. I think I have a deductible. What does that mean? Some people are very sophisticated and they've worked in healthcare before, so they kind of understand it better. But for the vast majority of people that are receiving services at a hospital or a clinic, even if they're highly educated, doctors, lawyers, engineers, most people have a general idea of how much they are going to have to pay for a healthcare service, but they have no real specific information. And that makes it very difficult to have, to make judgments or make decisions about providers that you select, about procedures that you do or don't elect to do. And then on top of that, you add sometimes I know we've talked about this on the show before when we were talking about value-based care, value return on investment. The idea that one of the big factors that gets talked around in healthcare too, that gets missed in healthcare, is that oftentimes, if it's an emergency situation, there is no shopping around. So you don't have time to look through, the 3 local hospitals and decide which one is going to be the most cost effective when you're having a heart attack or having a stroke. You're calling the ambulance and you're saying, get me to the hospital so I don't die, right? There's just a different level of decision making that is not normally in place in most economic transactions, where you're not sitting there, looking at all the costs, looking at adding all the numbers up and making a rational decision. A lot of times it's a go decision because it's an emergent issue that you need to get taken care of then. So that also adds a little layer of complexity. I think, every time somebody comes to me with a potential topic for a podcast episode, and it sounds something like maybe too good to be true, like this will stop all of your fraudulent medical bills, I always tend to look at it a little bit more nuanced, as a nuanced approach. And this is definitely one of those areas where this is what he spent a lot of time, what Frank and I just spent a lot of time discussing, was what happens if you go to or you receive services at a healthcare provider who is in network or is a participating provider with your insurance company. But what is happening more and more is that many provider organizations are simply not accepting insurance companies. And then it's a totally different ballgame altogether, because that middleman is not in the way, or if you would, and the bills really you would legitimately owe a bill, right? If they're an out-of-network provider and they don't need to accept assignment. So it's definitely one of those complex issues that has much more nuance behind it. I think his idea and his discussion here is valid for organizations that are in network, that are network participants of an insurance company. And it's interesting to note, like some of the points that he talked about, the way these contracts are written and structured and all of that, I think is super insightful and super interesting. I think the next iteration really is going to be, or the next level of the discussion really is going to be not just payment mechanisms, because that's, I think, part of it is having the network, the insurance network, and how that drives a lot of payment and maybe even provider selection. I know there's a lot of patients that will not go see a provider that's not in network. But as those networks begin to come under fire, perhaps, maybe, a big hospital system in your city decides to drop United Healthcare, decides to drop Blue Cross Blue Shield or whatever. You know, we see these things in the news all the time. It changes the dynamic. And I think going forward, especially with technology moving the way that it's going and value-based care really becoming a real viable option for a way to pay for healthcare, it's going to be interesting to see what the competitive landscape in healthcare on the healthcare payer side of things becomes. You know, like I was talking to somebody the other day that's trying to build this a big network of providers with the sole purpose of leveraging technology to garner value-based contracts, value-based healthcare contracts. And we could potentially see a world where the competition around who is paying for healthcare, that competitive landscape really turning into like a tech company versus insurance company, right? The insurance companies have a lot of dominance in the marketplace right now, and they've got the lobbying ear. They put a lot of money and effort into that, into maintaining the status quo. But the reality is, technology is the big unknown. It's the big disruptor, and I've said this for years that technology is going. If we implement technology, if we begin to implement technology throughout the process of care, it is going to necessitate that we change the way we view how we pay for and deliver healthcare services. So not just, you know, virtual service delivery, but how do we pay for it? What does that mean for payment? Or, you know, I've been very critical of like a fee-for-service payment model, but moving into value-based contracts requires a lot of data management, data analytics that a lot of small independent providers can't. They don't have the infrastructure to participate in. So, you know, in one of the episodes that I talked about, is value-based care going to destroy independent private practice? I did mention things like networks, you know, provider networks as being one of those ways, that independent healthcare providers can still maintain independence, but tap into some of these value-based contracting. So it's going to be interesting over the next, I would say, 5 to 10 years to really see how the pressure that we're seeing from like a political and regulatory standpoint on the healthcare system, how that affects value-based payment or value-based contracting, what players get involved. Because I can tell you, you know, Microsoft, Amazon's already doing this with purchasing primary care providers and the like. The big healthcare technology companies understand the potential value in healthcare as an industry, as a sector, and they're not going to be content to just come into the market and play the game the way it's currently being played, right? They're going to bring their innovative or even their technological background, their tech background, to really disrupt it in a way that I think is going to fundamentally change the way healthcare is paid for and delivered at least in the US for sure, in the developed world. And it's going to be very interesting to see how that plays into insurance networks and provider organizations and PPOs, HMOs, that whole thing, because depending on who wins the battle, right? If it's a traditional health insurance group like United Health Group, or if it's a technology company like Amazon, those are two very different worlds in the future of what healthcare will look like. You know, at the end of the day, healthcare is a human experience, and you are delivering services. It is one person skilled in the art of healing helping another person on their unique road to recovery, as I've said. The mechanism for paying for that relationship, though, really dictates a lot of how that relationship is formed, who is involved, the trust that is formed between the clinician and the patient, the end recipient. And I'm very hopeful that the innovation that is going to be brought to the industry by some of these larger technology firms really taking a serious look at healthcare means that we might end up being privy to a world where health care providers are being paid adequately, but also not squished into this treadmill or conveyor belt healthcare where they're trying to crank out as many patients as possible. It's going to be an interesting ride over the next several years for sure. So anyways, that's all I've really got to say about that. If you enjoyed the show, head on over to iTunes, leave us a rating and review. I will link to Frank's book, The Big Lie in My Healthcare Bill, Why I Don't Owe What My Insurer Fails to Pay. I'll link to that at the show notes. You can find that at rehabupracticesolutions.com. Click the link, the tab that says Insights, and there's a sub-tab there that says Podcast. Click on that, find the show. This is going to be episode, I believe, 150. We're 150 episodes in. Until the next time, folks, be safe, be healthy. I will talk to you then.
Thanks for listening to the Better Outcomes Show, where we explore the possibilities of a new healthcare. Our hope is that you walk away from each episode informed, equipped, and empowered to push the boundaries in your own practice or business. We want to give you the tools to help you build strong, long-lasting relationships with your patients and clients, helping meet their goals, improve their health, and achieve better outcomes. Learn more at www.rehabupracticesolutions.com. We'll catch you on the next episode.
Thanks for listening to another episode of the Better Outcomes Show with Rafi Salazar. This episode was brought to you by Strata PT. Strata PT is a single EMR platform and revenue cycle management service for physical, occupational, and speech therapy practices that helps you achieve a 99.99% reimbursement rate. If you'd like to learn more about Strata PT and see how their EMR and RCM works, head over to stratapt.com to book a demo.